On behalf of all the members of the Coalition for National Trauma Research, I want to welcome you to our What is CNTR webinar. My name is Eileen Bulger. I'm the chair of the board for CNTR and also the chair of the American College of Surgeons Committee on Trauma, which is one of the core members of CNTR. Over the next hour, we hope to provide for you an overview of CNTR and all that we think CNTR has to offer for those that are interested in advancing research to enhance injury prevention efforts and to improve outcomes for injured patients. Seems like we're pretty good. Okay, thank you, Pam. So, to start off with, I think we maintain that traumatic injury is really the most under-recognized public health problem facing our world today. Shown here in data from the World Health Organization, injury accounts for about 5 million deaths a year worldwide. And because it disproportionately impacts our children and our young people, then we all know it's a major cause of disability.
Thanks so much. No worries, thank you.
I ask you to mute if you're not speaking, please. So this obviously translates into a huge cost to society, and this is the last estimate that was done in 2013, suggesting that the annual cost per year in both medical costs and in loss of work-life productivity adds up to about $671 billion a year. However, despite these staggering costs, we really have failed to fund research in this area commensurate with that burden of disease. And if you look at this analysis that was done of all NIH funding in 2016, about 3.7% of all NIH grants were trauma-related. That accounted for $720 million, which is only 2.9% of the NIH budget. And importantly, there's really no coordinated effort because these grants were spread among 24 different institutes, ranging anywhere from 0.01% to 11% of an institute's budget. So it's a very small percentage of the federal grants that we issue for important health problems. Looked at another way here, you can see where they plotted the funding for research against the mortality rate per 100,000 population. And many diseases, particularly chronic diseases, are funded above the burden of disease. But if you look at the three mechanisms of injury, which Pam will highlight with a click, you'll see that motor vehicle collisions, gun violence, and falls all rank well below the rate of funding relative to the burden. Next slide, please. So this landmark report you're likely familiar with was published in 2016 from the National Academies. That really was a call to action to improve our national trauma care system. One of the key statements that was made in this report was that there was a gap in the investment in trauma research commensurate with the burden of disease, and it really called for a coordinated trauma research program which would focus on high priority needs and would provide adequate resources. And so this really was a call to action. However, if you look back at history, this is a recurring theme. And in fact, in every single report that's listed here, since the pivotal report in 1966, which was the first report to call attention to trauma as a public health problem, every one of these reports has called out this issue of insufficient funding for trauma research and lack of coordination. And in 54 years, we really haven't had any change. So, it felt like we needed to take a different tack, and CNTR was really born out of that mission. So CNTR is the Coalition for National Trauma Research, and this is a coalition of professional organizations that have come together to try to address this issue really in three ways. The first is to advocate for sustainable research funding commensurate with the burden of disease, so a really coordinated advocacy effort. But also to look at how we can better coordinate our research efforts across professional organizations that span the continuum of injury care. When I talk about the continuum of care, I'm talking about injury prevention, but also every point along the step of an injured patient. So from the point of injury with pre-hospital care all the way through to rehabilitation and reintegration. And then finally, we wanted to think about ways to strengthen the infrastructure to support multi-center investigation, because it's one of those things that if you build it, they will come. So where did CNTR come from? In the early 2000s, there was an organization known as TriStat, which was a collaboration among the trauma and burn centers in San Antonio to coordinate and advance trauma research. In 2006, under the leadership of Dr. Stewart, They broadened that mission to support this work nationally and were incorporated as the National Trauma Institute. Now, early on, the National Trauma Institute was actually awarded some direct funds as earmarked funding from Congress, which allowed them to award research grants to support small projects. But recognizing the need to conduct multi-center trials to really make significant advances, the NTI really evolved to serve as a research coordinating center and support grant applications. All along the way, though, they continued to advocate for increased federal funding. In 2014, Center was established as a collaboration between the American Association for the Surgery of Trauma, the Eastern Association for the Surgery of Trauma, the Western Trauma Association, the American College of Surgeons Committee on Trauma, and the National Trauma Institute in order to continue to advance these efforts, and the NTI staff served as the research infrastructure for Center. As was described here by Dr. Chaffee in his presidential address in 2014, the goal was that Center would speak for one voice about the need for more research funding for trauma, would maximize our resources, would increase collaboration on multi-center studies, and would really optimize the research committees across our professional organizations. They went on with additional targeted advocacy efforts, and you can see here the team from the Advocacy Day in 2018, where we went with trauma survivors from the Boston Marathon bombing, and these efforts were successful, adding about $10 to $20 million a year to the DoD budget to support trauma research, but really still a drop in the bucket relative to the burden of disease. So in 2020, we decided that the center really needed to be a sustainable organization. We were seeing early success. We wanted to make this sustainable, and we wanted to broaden engagement across professional organizations that really touch the trauma patient on every level. So we reorganized a center, and NTI was now incorporated as Center, changed its name. These are the current core members of Center. So the core members are the founding members that I discussed, along with the American Burn Association, who has joined at that level. We also have a number of stakeholder members, and affiliate members are starting to join. So we're working now on trying to reach out to all of the specialty organizations who might be interested in being part of this effort. And that is part of the goal of the call today. Again, wanting to cover that entire continuum of care. So this diagram shows how we're organized. Each of the core members has representation on the board, and each stakeholder organization has representation on an advisory council. And those two groups work together to help set the direction of Center, along with the Center program staff who do all the work. We have three main focuses of activity. We have a scientific advisory committee, which you'll hear more from today, that has been doing a tremendous amount of work in both building mentorship opportunities and in supporting grant applications. We have advocacy efforts, and then we have a new group that we're putting together to make sure that we have a good lens on equity, diversity, and inclusion issues throughout our work. Next slide, please. So there's a couple of special programs that I wanted to share with you to make sure that you're aware of that I think are unique resources to Center and will help us as we move forward. One is the National Trauma Research Action Plan. So this was a grant that was awarded to us from the Department of Defense. And this was, again, in direct response to the call from the National Academies to develop a more coordinated response to research. We've convened 11 Delphi panels that are executing a gap analysis of military and civilian trauma research and really identifying a roadmap of priorities across that entire continuum of care. And that work is well underway. Can you go back, please? And we're also looking at how we can better track long-term functional outcome metrics and other metrics important after hospital discharge and working on regulatory issues. But we believe that this project will help lay the framework for future work of Center. Next slide, please. In addition, with additional support from the DoD, we've established a National Trauma Research Repository. This work was led by Dr. Don Jenkins, and this houses data from completed multi-center trials to make it available for secondary analysis and for planning for subsequent studies. So again, a terrific resource to have available to the trauma community. Next slide, please. So in addition to the advocacy efforts, we've really leveraged the experience of the NTI staff who have been experts at grant writing and clinical coordination of centers studies to support investigators who are seeking funding for multi-center investigation. You're going to hear from some of those investigators today who have recently worked with CNTR on their experience. We've also built into CNTR an expert in geospatial mapping and geospatial analysis, which is a tremendous resource for some of our trauma system development projects. As a core member of CNTR, the American College of Surgeons Committee on Trauma has committed to support the development of this program through our Tequip data infrastructure. Our goal is to have the ability to collect incremental data on the Tequip platform that can seamlessly link to Tequip data that is collected for quality improvement activities and that can be used to support research projects. The Tequip program engages over 850 trauma centers in the US, so it's a large platform in order to identify clinical sites that could participate in research. We've requested each Tequip center provide a research contact. And we can use the data infrastructure of Tequip program to help identify metrics that will support site selection for multi-center clinical trials. So it's a terrific resource. This is a list of some of the recently funded projects that are all being managed by CNTR. I think as you hear from our Scientific Advisory Council, there are many more projects still in process, but I think you get a sense here of a diverse array of projects from multiple federal funding sources. Next slide. So I encourage you to visit our website for more information. Here you can see all the research sites that are currently engaged in CNTR studies, and you can click on each study to see who's participating in which study. But we are not an exclusive network. Our goal is to be open to identifying the best sites based on the parameters of the research project and not to be exclusive in any way. So I'm going to now introduce Dr. Ben Zarzar, who is going to be our next speaker. Dr. Zarzar is the vice chair of CNTR. He represents the Eastern Association for the Surgery of Trauma on the CNTR board. Dr. Zarzar has a long history of NIH funding and is currently working on collaborative care interventions to improve the long-term outcomes for older injured patients. He's a professor of surgery at the University of Wisconsin, and he's going to speak a little bit about some of the things that we think CNTR can offer for mentorship. So thank you, Dr. Zarzar.
Thanks, Eileen. I appreciate it. And I also appreciate the opportunity to talk to you guys about the great work that's going on with CNTR and the exciting future that I think it has. Next slide. So Eileen talked about the gap in funding that we see for injury research that isn't really commensurate with the burden of the disease. And there's another gap that I think we should also focus on that's starting to come our way, and that is this is true for not just surgeons, which is what this study was focused on, specifically trauma and acute care surgeons, but for many of the other specialties that also take care of the injured patient. So that would be orthopedics, emergency medicine. You can see the same types of trends that are occurring there. And this study, which was looking at academic productivity among surgical faculty, shows that there is a lag right now in those that are in fields like trauma focus fields in terms of productivity, particularly at the assistant and associate professor levels. And the professor level, which is kind of on the right-hand side of the slide, you can see fairly equal academic productivity at the time the study was done, which is around 2010. So, but the pipeline is starting to fall behind. Next slide. And this translates into not only lower academic productivity in terms of published papers and everything else, but also in terms of grant funding. Next slide. So when you look at this gap and sort of this impending gap and researchers who are dedicated and to advancing our care of the injured patient, I think we have to pay attention to this pipeline gap. And one of the ways that we've addressed that, and a lot of societies do this, is by providing funding and mentorship to young investigators. And these programs seem to work. About people who are funded by a scholarship, particularly focused on trauma. Most of those people stay in the field of injury, over 70%, and they're about 3 times more likely to get eventual R-level type funding, not necessarily from the NIH, it could be from the DoD, PCORI, R-level type funding for big research projects, 3 times more likely than those who do not ever receive this kind of support. So I think at least in early career, we have a lot of evidence that that mentoring really can help transform people from their current level to the next level. So I think Center is well positioned to help do that and is already doing it. Next slide. I think we have a lot of programs that focus on the young investigator, people just starting out. NIH gives a bump to people who are new investigators who've never submitted a grant before. But for those who are in their mid-career, there is not as much focus on mentorship. And there are a lot of opportunities where we can, as Center, start to work as a force multiplier for people in their mid-career to help them make difficult transitions with their research. And along with doing this, I think help improve the care of the injured patients, which is also ultimately the goal, I think, of Center and the work that we all do. So some potential areas where people can need help in their mid-career would be making the K to R transition. Only about 40% of people who are funded on a mentored K-type award make the transition to R-level type funding. People who are mainly bench scientists who want to bring their work from the bench to the bedside, that's another example. We have good examples of that going on right now, and Rosemary, I'm sure, will talk about that further along. If you've done well with single institution trials and you want to expand to a multi-center trial, that's where Center really helped me in my career, is take something that we had done in a single center and then as far as looking at a prospective database and then expanding that out and making it easy to do in a multi-center trial. People who are doing first-time PCORI or DoD, that's another focus of specialty that we have, and I think that's another group that we can help with. And there's a list of others, and you'll get the sense of that as this presentation goes on. But some of the specific things that I think Center does that really can help people make these types of difficult transitions are, you've already, I think Eileen mentioned the assistance with grant management. I can't tell you how important that is, particularly if you have a multi-site grant. And I'm not talking just 4 or 5 different places, but if you have 40 or 50 or 60 sites, trying to manage all that or have your Office of Research in your own department do that is really difficult to do. And Center's expert at it. Another thing that we have access to is a vast number of people who are well funded in many different areas. So we can form mentoring teams for people who want to make one of these transitions or to start a new area of research or to expand on an area of research that they're already an expert in. So those are taking advantage of those types of connections that Center has through its partner organizations is one of the things that we can do. Another thing that is super helpful is looking at previously funded grants and frankly looking at previously unfunded grants along with the reviews, because you can learn a lot about what the funding agency is looking for, as well as grantsmanship type tips from reading previously funded applications. So I think that's another thing that Center can do and help us with. Because we have different groups and organizations as partners, we can dig deep and form multidisciplinary teams. And we have examples of that ongoing right now with a couple of the studies that we'll talk about in a bit. With emergency medicine in particular is one of them, but we also have opportunities with rehabilitation and many other groups that we could work with or pull from in order to form really effective and multidisciplinary and interdisciplinary teams. And then, I think program development is another area where Center has been an expert and has been able to help people make a transition. And I hope that you get the sense that Center is well positioned to be able to take your any kind of research that you might be doing and then take it to the next level and help us really accomplish the mission of making the care better for our injured patients. And so the next speaker is Rosemary Kozar, who I think will help expand on that. Eileen, are you going to introduce Rosemary?
I am. Thank you, Ben, for that great summary. So Dr. Kozar is a professor of surgery and the director of translational research at the University of Maryland, R. Adams Cowley Shock Trauma Center. She has over 15 years of continuous NIH funding studying the endothelial dysfunction and hemorrhagic shock. And she is currently serving as the chair of the Scientific Advisory Committee for Center, and she's going to talk a little bit about how that group works and what they're working on. So thank you, Rosemary. You're muted, Rosemary.
You'd think after about 20,000 Zoom calls, I would have thought about that. Thank you. Thanks for the intro. And I just wanted to give everybody a little sense of what sort of who we are, what we've been working on, and what we hope to work on in the future. So this sort of all started when Eileen put together this methodology conference back in July 2019, realizing that clinical trials weren't just our standard prospective randomized clinical trials that we were all used to doing, but now are a whole variety of adaptive design. We learned about implementation science, de-implementation science. So we had all these experts from all over the countries and all different fields come and talk to us and sort of help educate us. And then based on this conference, we put together a couple of manuscripts that sort of summarize what we learned. And related to what Ben was saying, 3 of the papers that were basically the science papers had junior investigators or early career investigators as the primary author on these. And if you haven't seen them, I would encourage you to take a look at them. They're actually incredibly informative. Next, please, Pam. So this is just the members of the current members of the Scientific Advisory Committee. They're members appointed from all the core membership. And they've all done a really great job and have worked incredibly hard. So what we did, we sort of got together and talked about, how do we as a small group suddenly get all this funding. So what we wanted to do is sort of put our minds together and sort of at least get things off the road by ourselves. And then hopefully as this got bigger, we can invite other people and help other organizations and other groups. So currently Center, and Eileen gave you a little overview of this, is managing over $20 million worth of grants. She mentioned the NTRR, MIMIC, CLOT, and NTRAP. And just so the individuals on the call that are from non-traditional trauma organizations, Brian Eastridge's talk, which I think you'll hear about in a minute, has, orthopedic surgeons, neurosurgeons, trauma surgeons, medical examiners. It's a very multidisciplinary group that's working on this grant. And I'll talk briefly about a couple other studies that are multidisciplinary. We're also in the midst of contracting a DoD-funded multi-center burn study, so I've sort of incorporated some of our burn colleagues who are now core memberships into Center as well. So since the SAC has been together, we've submitted a number of grants. There was one been submitted by Center to the NIH, the Minority Health Disparities. There's been a DoD pre-proposal for a virtual reality program. And a full proposal that's been submitted to the DoD for burn dressings. And these weren't from our committee per se, but I just want to give you sort of an idea of the scope and the breadth and the number of grants that Center is currently managing. So these are some of the things that we have worked on so far. We have gotten funded a PROCORI implementation grant, and Elliott Howe will be telling you a little bit about that and his experience with Center. We've also been funded, it's kind of a long story, but Humacyte is a company who got funding through MTAC, who contacted us through the Prove It registry, which was initially a AAST funded study to look at vascular injuries, and that this contracting has gone out, so we've had some early successes. What we've submitted so far is a R2133 which Bilal Joseph is the PI on. He's going to tell you a little bit about this grant. It's a focus on geriatrics. Todd Constantini and Elliott had submitted an NIH NHLBI conference grant to look at different VTE practices throughout our country. Deb Stein has been the PI on a letter of intent we've submitted to PCORI for an engagement grant. In progress, we've submitted, and I believe soon is going to resubmit, a large UG3 grant to NHLBI. So we were contacted through the chair of the AAST Multi-Center Trials Committee, through Todd Constantini, by an emergency medicine physician who has a lot of experience with clinical trials and NHLBI, and wanted to do a large study. And he said, I need like 50 trauma centers. And so through the American College of Surgeons, using Tequip, we're able to identify his very specific patient population, contacted those centers, got the 50 some centers interested, and sort of help all coordinate this really massive grant that was looked upon very favorably. So we foresee that being funded. Next, please. And if anybody has any interest, and this is sort of a work in progress, but this is on the website. If anyone has any interest in working with Center and would like some assistance on any grants, we do have an application process on the website. We've been contacted through Ben, who you just heard from, had a vascular surgeon at his institution. She was interested in palliative care and wanted to do a study in trauma geriatric patients, and she reached out to us. So we're going to work with her in the upcoming grant cycle or two to work with the grants. And we're open to anybody from any subspecialty who has interest in working with our group. And I think you'll hear some really positive responses from people who have worked with Center in preparing their grant, and some who have already gotten funded in the recent future. And I think that's all that I have to say. And I thank you all very much for participating.
Thanks so much, Dr. Kozar. Now you're going to hear from three of our investigators. The first is Elliott Howe. Elliott is also serving as an East representative to the board at Center. He's an associate professor of surgery and the vice chair of quality, safety, and service in the Department of Surgery at Johns Hopkins. And he's going to talk a little bit about his experience in working with Center, extending really from single center to multi-center work. So, Dr. Howe.
Sure, thanks for the opportunity to talk today. I'm going to talk about a project that we just recently had funded by PCORI. I'll take a step back and say, I've been working with Center for about 4 or 5 years on this project run by Peggy Knutson as the PI, called the CLOT Consortium, the Consortium of Leaders in the Study of Traumatic Thromboembolism. It's a series of 17 trauma centers that have been doing some DoD funded work on DVT and PE after trauma for years, and you'll see a whole series of papers coming out, I would say, in the next 1 to 2 years from this collaboration. So I utilized that connection with both Center and that group, the CLOT group, to take a project that we had been doing at Johns Hopkins and had spread it out across our health system that had been funded by PCORI, that focuses on patients and nurses, to educate patients and nurses about DVT, PE prevention across a wide variety of patients, medical, surgical, et cetera. And decided that since DVT, PE is such a big problem after trauma, that this might be a great opportunity to focus down onto trauma across the country. So this project was recently funded. It's $1.4 million. We're going to work with 10 trauma centers across the country. You can go to the PCORI website and find more information here. And this is a dissemination project. And the idea is that we're going to scale a bunch of interventions that we've done and have shown to be successful locally to these 10 trauma centers, and then using pre-existing data, trauma registry data, and then some extra data we're going to pull out of the electronic health record, we're going to hopefully show that we can make a difference in these complications after trauma. So if you want more information on the specific project, you can go to the PCORI website and read about it. You can look on Twitter. There's been a bunch of back and forth, but the project is underway. Next slide. So here you have a list of the 10 sites that are going to be taking part of this. They're spread out across the country. Like I said, you can go to the Center website with that interactive map and take a look and see where they are. The other picture I have on here is a slide from the slide deck we used. We had our kickoff meeting a few weeks ago. And this is the stakeholder organizations that are supportive of this project and collaborating with us on this project. And you'll see a lot of the ones you might imagine in the trauma world. A bunch of the trauma professional societies for trauma surgeons, Society of Trauma Nurses, the American Trauma Society. We've also got support and obviously through Center with lots and lots of help through the COT and the East and Western Trauma and WAST. Also, we've got connections to some blood clot organizations. These are some are professional organizations and some are patient-run advocacy organizations to help us as key stakeholders in this project. If you move on to the next slide, you'll see that Center, honestly, I never would have been able to get this project and this application submitted without the help of Center. So for many of you who've written a grant and had a few letters of support, that piece alone is a decent amount of work. You cannot read the slide or all the pictures on the right side of the slide, and that's okay. Suffice it to say that is the table of contents of the letters of support that Center helped me get and collate from all the different trauma centers and all the key stakeholders. We had over 100 letters from all those different groups. In addition to all the key stakeholder groups, each of the trauma center, we got letters from the PI and the chief nursing officer and the chief informatics officer and a few other people to say that all those people would be willing to help and be involved in this kind of project. Just the letters of support was a huge undertaking. Then imagine now you're going to do all your budgets and your subcontracts and your subawards to these 10 trauma centers. And this is, I would say, a moderately sized multi-center study. It's not 2 or 3 centers, but it's also not 50. We have written a lot of grants and my team has a lot of experience doing that. But the extra expertise from Center in helping write this grant, I think was super helpful in getting this thing funded to the tune of $1.4 million. So now that was, a year ago, we were doing all that work. And we finally had the contract signed, sealed, and delivered with Peggy. Is going through Center and then, subcontracting out to all these different places. The next step, you also really need someone who's good at this kind of work. Project management, especially for researchers who really like thinking about the research piece. The project management piece might not be your favorite thing, and having experts who can help you with that is great. Subaward contracting. It's really difficult to go through my university potentially, but Center is used to subcontracting and ready to go with these 10 subcontracts to all the universities. Our institutional or our individual IRB, not that bad, but then we're working with all the other groups to get their IRBs to sign off and then sign off in the data use agreement so they can send the data to Johns Hopkins so we can analyze it. We're working on a publications planning committee. We're now having our kickoff webinar that had almost 100 people on it. All the communication, they're going to help us build a website. I think this is the kind of project that is right up Center's alley, has been super helpful. It's a win-win. I get a lot of the help that I need doing other pieces, and Center gets what I think is a really good project. And then moving forward, the idea is if we can show this works at these 10 trauma centers, the next project going in through Center is going to be a bigger, large-scale intervention, potentially, coming to a trauma center near you via Tequip and the American College of Surgeons. With that, I'll end. I think that might be my last slide. And I just want to say thanks again to Center, because I don't think this piece would have gotten funded without your help.
Thanks so much, Elliott. Another really fascinating project that involves a lot of moving parts is a project that Dr. Eastridge is going to share with you. Dr. Eastridge is professor of surgery and the division chief for trauma and emergency surgery at UT Health in San Antonio. And he's going to share his experience on this DoD funded project. So Dr. Eastridge.
Thank you, Eileen. And again, thank you for Center for everything they've put into this. So this is the MIMIC study, which is basically a multidisciplinary investigation looking at the impact of pre-hospital mortality. Well, all of us taking care of injured patients know that pre-hospital mortality is a significant cause of death in our trauma patients. We've always had a pretty good perspective of mortality once the patient hits the trauma center, but perhaps not as good as an understanding of the pre-hospital mortality, obviously because we didn't see it. So we know from the literature that it's not very well quantitated. We don't know really much about the survivability, and many of the basic premises were sort of at the basic tenets of the NASM report on zero preventable death and disability. So the goal of this study was really to get beyond the estimates of pre-hospital mortality and try to more objectively establish the impact of pre-hospital injury mortality on public health. Next slide. So the basic premise of the the MIMIC study is, again, I want to highlight that this was not only really fostered by the center group, but my co-investigators, Dr. Kurt Nolte, who was at the time the chief investigator and forensic pathologist at the University of New Mexico, as well as Ellen McKenzie, who is dean of the Bloomberg School of Public Health that everybody knows very, very well. The goal of the MIMIC project was basically to look at 3,000 pre-hospital deaths in 6 areas of the country shown on the map there. And those areas were actually specifically developed because those areas had comprehensive medical examiner systems where all of the mortality data is actually filtered into a comprehensive central data repository that was available for review. And ultimately, again, as I mentioned before, we wanted to develop a more comprehensive understanding of the epidemiology of these pre-hospital deaths and potentially identify ways that we can improve current trauma systems. It took a lot of work. It's a lot of logistics that I'll go through here shortly, but we needed to create a framework and a methodology to do these evaluations. We also wanted to keep the lexicon relatively in line with what the Department of Defense was doing. So again, we're thinking about it from the perspective of a single trauma system. We knew this effort had to be multidisciplinary and multi-institutional. So we wanted to maximize inclusivity of specialties and institutions. We're in the process of looking at those 3,000 cases to define sort of the epidemiology of pre-hospital mortality. And once we get all this data together, ultimately we'd like to put it together as potentially a blueprint for sustained effort to identify high yield areas for research and development to improve trauma systems and for injury prevention in the future. Next slide. This is the basic schematic of our study, including the locations that we chose for review, the potential or the sources of data that we used in doing those reviews. All of that data is abstracted, put into a REDCap database. We also put accessory information in there, such as NEMSIS data in decedents that had an EMS intervention or an EMS interaction. All of the injuries are coded. And we also hired a really super GIS specialist to augment the project, and he has really been indispensable. We also worked with Johns Hopkins to develop an excerpt of that data that will go to these multidisciplinary review teams, of which there are 14 review teams made up from multiple specialties that do the reviews on this electronic data portal. If they reach consensus, that's basically that ends the review.
¿Está perdido?
Somebody's not on mute.
Yeah.
Then the
Está perdido.
subsequently go to secondary.
Está perdido.
Next slide. So the center has really been indispensable to doing this project. You can imagine with all of the institutions involved, the granting agency, They were really had a tremendous effort in working with the granting agency, coordinating the numerous investigators, developing a steering committee to actually develop sort of a framework for the project itself. The budget development and administration, you can imagine, are extremely complex, thinking about the number of organizations that are involved in this. The subaward contracting to the medical examiner sites, they were instrumental with sort of the research and the IRB as the IRB liaison. They helped develop the REDCap and facilitate the REDCap database development. Developed the study data dictionary along with the steering committee. All the training was of the ME sites in how to abstract these records for review by the review teams was actually done by the center staff, and they routinely checked the QA on all the data. Next slide. With respect to the data coordination, this piece is actually much more complex. Certainly, this is something that is really beyond the scope of one individual's ability to do it. And again, I could not have done this project without center's support. Again, the geospatial mapping expertise has been a tremendous augmentation to the project. The relationships between that have been developed with NEMSIS and also specifically the state EMS data managers who really keep and retain the data. Those linkages had to be made with a lot of personal interaction so that data could be abstracted into the data repository for the study. Next slide. And then finally, again, even more complex, the center staff does a tremendous amount of program management. All of you working with your various partners at work, you can imagine the complexity of now trying to ride herd on multiple specialties of about 80 to 90 investigators in multiple fields across the United States. A tremendous amount of work goes into that in developing and really sort of facilitating these 14 multidisciplinary review teams of about 80 to 90 individuals. The case tracking, the management of the adjudication process, so for those that don't make it through clearance in the primary round, again, pushing those into subsequent rounds to get those cases closed. They provide a tremendous amount of support for meeting logistics and travel and presentation and publication support. So can't say enough really good things about what center has to offer and their ability to facilitate particularly highly complex research projects.
Thanks, Dr. Eastridge. Our last investigator is going to share his experience with you is Dr. Bilal Joseph. Dr. Joseph is professor of surgery, chief of the Division of Trauma, Acute Care, Burn, and Emergency Surgery at the University of Arizona. He is a representative to the Center Board from the Western Trauma Association. He has extensive clinical research experience, but he's going to talk about his recent grant submission for a multi-center trial network for geriatric trauma. So, Dr. Joseph.
Thanks, Dr. Bulger, and thanks, everyone. So I know a lot of you were probably sitting there thinking, you know, will this ever be me? And I was many times in my career sit there and say, am I ever going to get to that point of funding a trial such as this? And really what I want to convey to everyone is like what center did for me this past, few months as we went forward with this grant. So my first submission of this exact RFA and grant was in 2018, and I just put the number of pages that we submitted at the time. And we worked through our institution, and we had, it was a multi-center grant to look at developing an infrastructure that was in place to help define how clinical research in geriatric trauma would occur over the next few years. Click next, Pam. And this is basically the equation of what happened in the last 3 years. And it's not just the number. The quality is a bigger part than the quantity. And the reality is grantsmanship is very difficult. And for a lot of us, we're learning as we go and every time we get a rejection. But I can tell you what I experienced, the mentorship happens at so many levels, not just the junior investigator, even a well-seasoned investigator. There's a lot to learn when you surround yourself with what center offers. Next slide. And really, I only have this slide to present, and this try to explain to you what I experienced through Center. And when you look at the word grant, like, so guidance and groundwork, it was well established. There's lots of experience. Any type of trial that you bring forward, and you can just go to the website and see that. But the reality is the guidance was throughout the process, from start to submission. And the groundwork was the foundation of the success in the previous grants. I mean, even with 3 years of submission, I felt like we submitted a brand new grant, and I was supposedly the content and grant expert. But by the end, I learned there was so much more that I wasn't able to do. But when we looked at resources and rationale, I mean, the NTRAP, defining the prioritized research questions, what we were asking, and the rationale, really our specific aims page changed so many times. And eventually the final product, I was like, man, this is what I wanted to say, but I just really never knew. And it was really about being in the ballpark, but just needed that team to help get that home run. And it was really surrounding yourselves with the experts. Attention and administrative support, you heard this from Dr. Eastridge and Dr. Howe. I mean, the amount of support was surreal. And, we submitted over 50 letters of support. At times it was like a full-time job working with the team. And it was like, but the reality was they never made me feel that I wasn't part of it or wasn't my grant. It was really, bringing me in to actually, integrate with what was there. But all along, I was part of it. When you look at networking and national platform, I mean, Center's core members allowed for cross collaboration and support. Even the national societies, our ability to connect with the stakeholders that belong to Center. I mean, it just brings a whole nother level. One of the big things about this grant is the long term. How is this grant going to sustain itself? Will this be the future? What happens when the money goes away? And so what it brought was organizations and grant application that was very different. And then finally, technical expertise. I mean, grantsmanship is a language, it's a whole world that often many of us learn over and over. And I think it wasn't just getting the grant in. I mean, throughout the whole process, the mentoring that occurred was just second to none. And the people that we were exposed to, it just was amazing. So that's my 2 cents on my experience through Center.
Thanks so much, Dr. Joseph. So I'm just going to summarize. I think that we probably have 2 audiences on this call. Some of you are individual clinical investigators trying to figure out, what Center can do for you. And I think others are here representing professional organizations. So I'll start with just for the individual clinical investigator. I think what we can offer, as it continues to grow, is access to the National Trauma Research Repository, which will help with sort of pooling data from previous studies and understanding where things worked and where they didn't to help us design future trials. Obviously, you've heard that there's a lot of support for grant submission and study management, access through the Tequip platform as a framework for data collection, access to the Trauma Center network through Center, managing study subcontracts, regulatory documents, all of those complicated things that they talked about. Or if you want to do a project that involves sort of geospatial mapping analysis, looking at trauma system design, there's expertise in-house to do that as well. Again, we hope to offer mentorship specifically targeted at new but mid-career investigators. And then, we're continuing to look at opportunities to advance our own education as research evolves and research strategies evolve through research development and advocacy training seminars. I think that Center will also help amplify your research, just through our social media and blog accounts. If you're a professional organization, I'm hoping that you're excited now to join Center and add your voice to the advocacy for enhanced funding for trauma research and to really support efforts to coordinate a multidisciplinary research approach. As we wrap up the NTRAP, which has involved pretty much every professional organization that we could contact. We want to look at implementation of that, and we really want to do that in a very structured, coordinated way. And so we really need every voice at the table. And in addition, that belonging to Center provides benefits to your members of your organization. All those advantages that individual investigators have, your members would have as well. So I really want to thank our current members. And again, we have reached out to several professional societies that I think are contemplating membership. And so we're hoping that this will continue to grow, because I really do think that if we're going to achieve our goal of both on the advocacy side of enhancing funding, but also on the real side of providing a coordinated structure to this type of research, we need to get the whole house of medicine that cares about injured patients working together. And that's really what we're about.